Okay, so I'm going to go ahead and try to finish up this section on ears for you real quick. We stopped on, I don't know, it's page 19 in my notes. I'm not sure what it is on yours, but management of hearing impairments. So we discussed hearing aids helping conductive hearing deficits best, and how they take a significant adjustment period. So I was telling you about that with my father. Sign language, speech, reading lips is how they're going to, what we can do to help better assist those that are hearing impaired. Cochlear implants are going to be used for severe sensory neural hearing loss. And then we've got nursing interventions and approaches, and we're going to observe for signs of hearing deficits. Oftentimes people prefer not to admit that they have a hearing deficit because it means they're getting old, and they don't want to admit that they're getting old or that they're aging. They're very conscious about it. It's a stigma, or that they may be disabled. That book I told you I was listening to in the car, and that was her big thing, was she felt like it was a stigma that she was disabled by having the implants. We're going to determine communication method the client prefers. Do they prefer to read lips? Do they prefer to have an interpreter do sign language for them? Do they prefer to do pen and paper writing, or a whiteboard for writing down what's going on? Do they prefer a typewriter or a computer to just type out what's going on? We need to eliminate as much background noise as possible. Do not yell. That is the biggest thing. As someone said in class the other day, they tend to speak very loud, so we tend to yell right back at them. But there's no point in yelling. Speak facing the client in a normal tone of voice at a normal pace so that they can hopefully read lips. Use adequate lighting. Use gestures. I talk a lot with my hands, especially for my patients who are Hispanic. Rephrasing when not understood. So I was speaking about my Hispanic patients. I tend to do a lot of signing or charades. That's what I call it. Trying to do charades to motion out what I'm trying to get through to them. Be positive, be patient. Place a note on the intercom button so that the person on the other end answering it knows that this person is hearing impaired, because it's not going to do any good for, can I help you? Can I help you? Can I help you? And then they say, well, I guess they didn't need anything, when the person really did need something. Provide an interpreter if they want sign language, pen and paper if they want pen and paper, assist with hearing aid insertion and maintenance if needed. All right, moving on to otitis media on 689, I think, in your book. All right. So otitis media is an inflammation or infection of the middle ear. It may be acute or chronic, suppurative or purulent, or secretory, serous, or non-suppurative. Okay? So those are the different forms of otitis media. So otitis media is when the middle ear is infected, pressure builds up, pushes against the eardrum. When the pressure is very high, it perforates the eardrum, the tympanic membrane. So you'll see here is your normal pearly gray, which to me that seems not normal, but that is your normal eardrum, pearly gray. And here's your one with otitis media, and you can see that it's bulging. You can see this drainage back here behind it, this redness. Okay? But if this pressure builds up too much, then what happens is they'll get a perforation. So literally the pressure will make a hole in the tympanic membrane here so that all that stuff can drain out. Most ruptured eardrums heal within 3 months. If it is a very slow healing, if it's very slow to re-heal that ruptured membrane, then it may require surgical intervention. So this happens a lot with my boys. I can vividly remember for years, they've had multiple sets of ear tubes, and when the tubes weren't working or when they weren't in, when they would come out and they would just be crying in pain. Oh, it hurts, it hurts, it hurts, and they couldn't go to sleep. And then all of a sudden they'd be like, okay, I'm fine. And they'd go right to bed. It always seemed to happen at night because it hurts worse when they lay down. That pressure builds up when they lay down. When they sit up straight, the pressure's kind of down. It's not as painful. And the next morning I get up and they'd have just gobs of drainage pouring out their ears, whichever one ruptured. And I just knew that one of the membranes ruptured. So the issue with that is that physicians, ENTs prefer not to have the membranes rupturing frequently because it is much harder to heal. So that's when they go in and put ear tubes in. They make a surgical incision. They put a little tiny little ear tube in to keep an opening there constantly so that any kind of infection that builds up will just automatically drain out. Therefore, you don't have these continuous perforations happening. Okay, when you get a perforated eardrum, you're going to have some hearing loss in there. Okay, acute otitis media is most common in infants and children under the age of 3 due to the shorter and more horizontal eustachian tubes. Prompt treatment is important to prevent prolonged accumulation of fluid in the middle ear, causing chronic serous otitis media. Causes can be disruption of the eustachian tube patency, suppurative or purulent otitis media, which is usually a bacterial infection. Pneumococci, Haemophilus influenza are very common offenders. Can become chronic if it's inadequately treated, and usually begins as a upper respiratory infection. So this is what happened to my boys pretty much every single time they got a cold. This buildup of the all the drainage and congestion between the eustachian tubes would cause these ear infections. Secretory otitis media is a collection of pathogen-free fluid behind the tympanic membrane from a respiratory allergy, enlarged adenoids, or pressure injury, which can also become chronic. Complications are rare if we have adequate treatment, but you can get a rupture of the tympanic membrane, which we've talked about, and it may reduce the hearing acuity and increased risk for repeated infections. However, once that membrane ruptures, the person with the immediate ear infection feels much better because all that pressure is draining out, so it's not painful. You can get mastoiditis, which is an infection that spreads to the mastoid bone back here behind the ear, causes redness and swelling and fever. Okay. We can get labyrinthitis, which is infections that spread to the inner ear associated with vertigo. You can actually get meningitis, a brain abscess, septicemia, facial nerve damage, and paralysis from the infection. Permanent hearing loss. So one of my boys does have some, it's very minimal, but does have some permanent hearing loss from the, although he had multiple sets of ear tubes, I think he had maybe, I don't know, I want to say between 5 and 7 sets of ear tubes. He also ended up with a perforated eardrum, and I don't think it's actually even healed yet still. And they kind of want to go in and do surgery, and I'm kind of just hanging back on it. I don't want to do it just yet. So, knowing that though, I have to make sure that the teachers know, that he's aware that he has a hearing loss. You know, it's very minimal, but he does have one. And so that he's paying attention when he's being spoken to and things like that. Let's see. Assessment for otitis media. History of recurrent upper respiratory infection or allergies. They report severe, deep, throbbing ear pain. I mean, they're very painful. I don't know if you've ever had an ear infection as an adult, but I've heard a few people talk about it, and they talk about just how very miserable it is. Dizziness. With otitis media, we may have dizziness, nausea, vomiting. When the inflammation spreads to the inner ear, it'll mess with that 8th cranial nerve, the vestibulocochlear nerve, which maintains your balance. Get a sensation of fullness and popping and crackling or clicking sounds in the ear every time you swallow or move your jaw. This is often acute secretory otitis media and occurs from increased pressure. And my boys complain about this a lot. Now they don't have the tubes, but they'll often complain, I just keep hearing all this crackling. I keep hearing all this noise in my ears. The eardrum will look red and bulging. They report pain that suddenly stopped once the tympanic membrane ruptures. A mild to very high fever with some malaise. And you may have tinnitus or diminished hearing. In diagnostic tests for the otitis media, we're going to do an otoscope or neuroscopic exam, which examines the nerves the neuroscopic exam would. For diagnosis, usually it's just going to be an otoscope. Culture and sensitivity of the exudates, possibly blood cultures if they're really ill or if they have repeated otitis media infections. So we've had this done also with my boys who, because of the chronic ear infections constantly, they go in and they literally take this little tiny vacuum in there and suck out some of the exudate when they have an ear infection, and then they culture it and send it off to make sure that they're treating with appropriate antibiotics, because why do they keep getting these recurring ear infections? All right, here's your otoscopic exam where you can see the eardrum in here. Treatment for otitis media. We're going to do antibiotic treatment. Suppurative otitis media is bacterial. We're going to use antibiotics. However, there is a common thought process that we have an overuse of antibiotics leading to antibiotic-resistant microorganisms. So pediatrics especially, they may need larger doses or longer periods of medications to treat chronic otitis media. You can do acetaminophen for pain and fever, codeine for severe pain, although I've never had that prescribed or seen anyone prescribe codeine for the ear infection, but that is a possibility. We do the Valsalva's maneuver. They'll ask them to, and that's what I was telling you about before. When they hold their nose to pop the, open up the eustachian tubes is very similar with doing the Valsalva's maneuver. It's the same thing. You're trying to do the Valsalva maneuver several times a day for acute secretory otitis media just to inflate the eustachian tubes in there. It changes the pressure and relieves the symptoms of fluid buildup. However, like I told you before, sometimes it hurts, so the kids won't do it. Like my kids won't do it because it hurts when it pops. We may do decongestant therapy, which we've done multiple times. Lots of allergy medications trying to prevent that fluid buildup. Allergen elimination or an adenoidectomy. Tonsils and adenoids can harbor bacteria leading to chronic ear infections, which usually when you get ear tubes, you get an adenoidectomy. Not always, but a lot of times you will. So, of course, mine have had that as well. And we may do a myringotomy or a tympanotomy for severe painful bulging of the tympanic membrane. And it's basically where they're going to go in and do a surgical opening of the tympanic membrane to facilitate the drainage and pressure, at which point then they put in a tympanostomy tubes, a T-tube is what they'll call it. And they're actually shaped like a little tiny T. See if I can find one. Post-myringotomy, you're going to maintain drainage flow, place sterile cotton loosely in the external ear and change it when it gets damp, washing hands well before and after. If you got a myringioplasty or a tympanoplasty, is the repair for the perforated eardrum, closes up the perforated eardrum. Okay, so the myringioplasty or tympanoplasty repairs the perforated eardrum, so that's when they close up that perforation. That's what they want to do to one of my boys that I haven't done yet. And then we've got a mastoidectomy for mastoiditis, and it removes the diseased tissue. It's very rare. It's a kind of invasive surgery. Be sure that you understand all of those, the different types of otitis media, the treatments, the myringotomy, myringoplasty, mastoidectomy, what we're going to do for which type of otitis media, okay? Reality check. How does otitis media cause mastoiditis? And basically pathogens spread from the middle ear to the mastoid process. All right. Clear and concise explanations are what we need to do. Anticipate a hearing loss when you're doing teaching. Stress the importance of taking all antibiotics as prescribed. I have a really hard time with that with my kids who their ears start feeling better 3 or 4 days into the antibiotics, and then they think they don't need to take them anymore. Reinforce home instructions such as earplugs for swimming. Notify the doctor if your tubes come out. Ear pain, fever, thick ear discharge. And hearing loss from otitis media is usually very temporary. It's because of all the drainage and all the nasty stuff in there. All right, preventing otitis media. We're going to do early treatment of upper respiratory infections. Do not feed an infant or a baby in the supine position or place them in bed with the bottles, because basically it pulls the nasopharyngeal flora into the middle ear and can block the tubes and build up pressure. Valsalva's maneuver several times a day to promote eustachian tube patency, and after the tympanoplasty, you're going to avoid blowing your nose and getting your ear wet. Okay? All right, otosclerosis. Oh, I still got quite a bit to do here. All right, let's see how fast I can get this done. Otosclerosis. Otosclerosis, this is with the stapes. A fixation of the stapes is the most common cause of conductive hearing loss. Signs and symptoms usually develop in the 20s and 30s. I'm going to go kind of quick here so you can see the causes are on your sheet as well as the complications, unilateral to bilateral conductive hearing loss. Assessment findings for otosclerosis, it's going to be a very slow progressive hearing loss in both ears. It can be unilateral. Oftentimes it'll be both ears. Symptoms are usually first noticed when the person can't hear during conversations. Then we've also got tinnitus, and some will experience vertigo when they bend over with the stapes. Diagnostic tests, we've got the Rhine test, which we've already talked about, audiometric testing, and possibly we may need to do a CT scan to show the extent of bone growth there. Treatment for otosclerosis. A hearing aid may improve hearing impairment, but more often than not, a stapendectomy needs to be done. So a stapendectomy is an incision made behind the ear, postauricular, that's behind the ear. They remove the stapes and insert a prosthetic stapes, this whole thing right here. And I'm pretty sure there is a video on Blackboard. Be sure you watch it. Post-op treatment includes hospitalization for 2 to 3 days and antibiotics. Positioning of the client. So here's another important factor is positioning. So if you want to position on the non-operative side, so if I operated on the right stapes, I want to position on the left side. Activity is restricted for 24 hours or more. And there is a large concern for dislodging that prosthetic stapes there. Facial nerve function is assessed. It's a high risk of injury. And how are we going to assess this? So hopefully you remember your cranial nerve testing, your smile, frown, facial grimacing to test that cranial nerve. All right, the nurse provides post-op instructions to be followed until the release. Dizziness is common. Get help with ambulation. Sneezing and coughing with an open mouth. It can cause dislodgement. Okay. Ear packing, swelling, or fluid in the ear can interfere with hearing temporarily. Excessive ear pain or drainage should be reported. Okay, it's going to be slightly painful because you had surgery, but excessive ear pain or excessive drainage needs to be reported. Avoiding loud noises and sudden pressure changes such as diving. Don't blow your nose because that increases ear pressure. Protect your ears from the cold or wet. Avoid activities causing Valsalva because that's going to do a pressure change, obviously. And avoid people with upper respiratory infections. So this time of the year, just don't go out of your house. All right, change external ear dressing and incision dressing as instructed. Washing hands well before and after, but you do not remove the packing. You're going to complete the antibiotics and return to the physician as scheduled. All right, Meniere's disease here. It's on 693 and 696. Meniere's disease, you can see the definition there. Essentially, it's an excess of fluid problem. So the signs and symptoms triad, there's a triad of hearing loss, vertigo, and tinnitus. So that is kind of classical for Meniere's, this triad of hearing loss, vertigo, and tinnitus. Etiology is unknown, but you can see there are some theories of etiology. Assessment is going to be what we would expect to see are included with that triad of Meniere's. So with severe whirling, dizziness, and vertigo with nausea and vomiting, tinnitus, unilateral hearing loss, progressive nystagmus, an imbalance in the vestibular control of eye movement. So we saw that on that video that we watched. Attacks can last minutes to weeks, but most resolve sooner rather than later. Often the onset is very abrupt. It's very disturbing. People have no idea when it's going to hit them. They're very fearful of leaving home, often able to work. You have to rule out other causes because there's no definitive, this is Meniere's disease. Okay. Diagnostic testing is this caloric stimulation test, which uses temperature differences to diagnose the damage. So when cold water enters the ear, it causes rapid side-to-side eye movement. So we watched that video. And go back and watch that video again. The eyes should move away from the cold water. Next, warm water is placed in the ear, and the eyes should move towards the warm water. And I don't think that they did the warm water. I think they just did the cold water in that video. Abnormal results indicate neural damage. So you can experience extreme vertigo with nausea and vomiting from that cold water. Electrostegmography, CT or MRI to rule out tumors, audiometry, and electroencephalography, which confirms diagnosis. It records electrical activity in the inner ear as it responds to sound. Treatment in nursing care: prohibit smoking because it causes vasoconstriction, which interferes with fluid drainage. Bed rest with limited movement, providing safety during an attack. Teaching to avoid any allergens and taking any histamines if prescribed. If the PCP orders a hearing aid, then refer them to an audiologist. Medications, are on page 696 in your book. Be sure that you know what medications and why what the medications do. So there's meclizine, diazepam, promethazine, and hydrochlorothiazide. So meclizine is an antihistamine which suppresses the vestibular system. Diazepam is for acute episodes. It's not long-term because it's very addictive, but it does control the vertigo. Promethazine is an antiemetic for the nausea and vomiting. And hydrochlorothiazide is a diuretic, so it decreases the fluid and can help alleviate the symptoms. Okay, be sure you understand those. Surgery on page 696, box 43.3. Examples include an endolymphatic sac decompression, where they shunt the endolymph. Middle inner ear perfusion. We may have ototoxic antibiotic infusion into the middle and inner ear. There is a very high risk of hearing loss with that. And a labyrinthectomy. So we may do a labyrinthectomy. There is a very high success rate with that. However, the complication is the potential for facial nerve damage. So again, you're going to assess the cranial nerves. Go back and review how you're going to do that. Provide extensive psychosocial support during attacks, administer meds, limit movement, promote safety, assist with ADLs. You can read all that. Low sodium or salt-free diet. So what foods would be restricted on this diet? Reducing amount of sodium leads to reducing the amount of fluid intake. So we're going to reduce table salt, sauces and dips, processed foods, cured meats and bacon. Drink sufficient fluids, but limit coffees, teas, and sodas. They're diuretics. Eating fresh fruits and vegetables, we're going to encourage. Whole grains, we're going to limit alcohol intake. It's a diuretic as well. And avoid aspirin, because aspirin is an ototoxic medication to begin with, and it can increase vertigo and tinnitus. Okay, so I went through that very quickly. I'm very sorry. Please send me any questions. Email me if you have any questions about this. I did talk to Miss Greenlease, and we're gonna change up a few things. So I have 6 questions on exam 3, and I will have 9 questions on the final exam now. I'm not exactly sure how I'm going to divide that out. When it gets closer, I'll let you know. So that's different than what I had told you guys the other day. So I now have 6 questions on exam 3 and 9 questions for the final. But please email me if you have any questions about this material, since I went over it kind of quickly, and I know I talk really fast, and of course I'm running out the door to go to a soccer game right now. So let me know if you have any questions. Thanks.